Hello everyone and welcome to this session on medical coding guidelines for myocardial infarction, brought to you by Visu Online Medical Coding Training. Myocardial infarction, or MI, is a critical area in healthcare documentation. Today, we will bridge the gap between clinical understanding and coding accuracy, helping you step into your success as a professional medical coder regardless of where you are learning from. Let us start with the basics. A myocardial infarction, commonly known as a heart attack, is a life-threatening medical emergency. It occurs when a coronary artery, the pipes that supply blood to the heart itself, becomes blocked. This blockage reduces blood flow, and because blood carries oxygen, the heart muscle begins to suffer damage or even die. Quick intervention is vital to save as much heart tissue as possible. To code accurately, we must understand the pathophysiology, or the why, behind the event. Most MIs start with the rupture of atherosclerotic plaque. Think of this as a buildup of fatty material in the artery wall that suddenly breaks open. This rupture triggers the formation of a thrombus, or a blood clot. As the clot blocks the vessel, oxygen supply to the myocardium drops, and if the blood flow isn't restored quickly, myocardial necrosis, which is the permanent death of heart tissue, develops. To help you better visualize how a heart attack happens and how the blood flow is interrupted, let's take a look at this informative video. It provides a clear animation of the internal processes we just discussed. Not all heart attacks are the same, and the ICD-10-CM manual distinguishes between several types. We have STEMI, where the sense segment on an ECG is elevated, indicating a full blockage, and STIMI, where the blockage might be partial but still causes damage. Beyond that, the clinical community classifies MIs into types. Type 1 is a spontaneous event like a plaque rupture. Type 2 is a supply-demand mismatch, such as when the heart beats too fast during another illness. Type 3 refers to sudden cardiac death, and types 4 and 5 are related to surgical or procedural complications like stents or bypass surgery. How do doctors diagnose an MI? It is a combination of three things. First, clinical symptoms like crushing chest pain, sweating, and nausea. Second, ECG changes that show us the electrical activity of the heart. Third, and very importantly for coders, cardiac biomarkers like troponin levels. When heart cells die, they release troponin into the blood, making it a definitive marker for an MI. Imaging like angiography may also be used to find the exact location of the blockage. Once diagnosed, the medical team acts fast. You might see the MONA protocol in the charts, which stands for morphine, oxygen, nitrates, and aspirin. Treatment then moves to opening the vessel, either through clot busting, drugs called thrombolysis, or procedures like PCI, where a balloon or stent is used, or even CAB, which is open heart bypass surgery. Understanding these treatments helps us verify the severity and type of MI in the patient record. Now, let's get into the core coding guidelines. In ICD-10-CM, we use category I-21 for an acute MI. It is important to note that the acute phase in coding terms lasts for 4 weeks from the onset. You must assign the specific code for STEMI on STEMI based exactly on what the physician documents. If the patient has another MI within that same 4-week window, we shift our coding to category I-22. Remember, as coders, we always follow the physician's specific documentation. Sequencing is vital for accurate reimbursement and reporting. If a patient is admitted primarily for an acute MI, that MI code must be your primary diagnosis. If they have a second MI while still in the 4-week window of the first, the subsequent MI code is sequenced according to the circumstances of the encounter. Always be sure to code any resulting complications, like heart failure or arrhythmias, additionally, and always follow the official ICD-10-CM sequencing rules. Let's look at some practical examples. If a patient has an acute STEMI of the anterior wall, we would look at code I-21.09. If the documentation shows an STEMI confirmed by elevated troponin, the code is I-21.4. And if that same patient suffers another MI within 4 weeks of the first, We move into the I-22 category to show it is a subsequent event. These distinctions are the key to high-quality medical coding. From a clinical perspective, keep an eye out for these features in the patient's history: severe chest pain that often radiates to the left arm, shortness of breath, and extreme anxiety, often called a sense of impending doom. Be aware that symptoms can be subtler in certain groups. For example, elderly patients and those with diabetes might only report fatigue or nausea rather than classic chest pain. To wrap up, let's test our knowledge with some quick questions. Can you define what an MI is in your own words? Do you know the difference between a STEMI and an STEMI on an ECG? Which specific biomarker is the gold standard for confirming an MI? And remember our coding rules. How long does the acute phase last, and which code category do we use for the initial event? Finally, let's look at a few more advanced points. What exactly causes a type 2 MI? What is usually the first-line diagnostic test when a patient arrives at the ER? What does the procedure PCI stand for? And when exactly do we switch from using I-21 codes to I-22 codes? If you can answer these, you are well on your way to mastering MI coding. Thank you for joining us today.